The term aldosterone escape has been used in two different settings. One, in primary hyperaldosteronism, it is the escape from the salt and water retaining effects of aldosterone. Two, in the treatment of heart failure with angiotensin converting enzyme inhibitors, it is a breakthrough occurrence of aldosterone effect. In primary hyperaldosteronism, the escape from the salt and water retaining effect of excessive levels of aldosterone is considered to be an important homeostatic mechanism and thought to be dependent on nitric oxide. Natriuresis produced by elevated levels of atrial natriuretic peptides is another proposed mechanism for escape from the salt retention in this situation. Pressure natriuresis is another proposed mechanism for aldosterone escape with increased renal arterial pressure induced natriuresis. Aldosterone escape in the setting of primary hyperaldosteronism may have an important role in reducing the severity of hypertension in the condition. Aldosterone escape is the reason for edema not being a prominent manifestation of primary hyperaldosteronism. This mechanism does not work in aldosterone excess of edematous conditions like congestive heart failure and cirrhosis liver, possibly due to the renal hypoperfusion, which is not a feature of primary aldosteronism. In chronic treatment of heart failure with angiotensin converting enzyme inhibitors, it is thought to be mediated by potassium-dependent aldosterone secretion, which is unrelated to the renin-angiotensin-aldosterone system. Potassium is one of the important stimuli for secretion of aldosterone from the zona glomerulosa of the adrenal cortex. This type, in which plasma aldosterone levels return to pre-treatment levels in over a third of patients treated with angiotensin converting enzyme inhibitors or angiotensin receptor blockers, is better termed aldosterone breakthrough according to some authors. This is one reason for the current practice of adding a mineralocorticoid antagonist to angiotensin converting inhibitor or angiotensin receptor blocker in the treatment of heart failure. First set of references on aldosterone escape. Second set of references on aldosterone escape. Excessive aldosterone is produced by adrenal glands and adipose tissue in obesity. This explains the sensitivity of heart failure in obesity to mineralocorticoid receptor antagonists. Epicardial fat thickness has been shown to be increased in primary hyperaldosteronism. So, aldosterone secretion enhances fat deposition and fat deposits enhance aldosterone secretion. Primary hyperaldosteronism is associated with increased left ventricular mass and cardiovascular risk. Transition of epicardial fat from a nourishing tissue to pro-inflammatory tissue is mediated by aldosterone. Pro-inflammatory cytokines and migration of mesenchymal cells have a role in cardiac fibrosis. This will explain the role of mineralocorticoid antagonists in preventing cardiac fibrosis in cardiac failure situations. Experimental studies also support the role of aldosterone in the genesis of cardiac hypertrophy and fibrosis in metabolic syndrome.